This talks about hierarchy. So there's a few pieces to this, but the biggest piece is diabetes. Hypothetically, there's the diabetes which is with acute complications like DKA. There's diabetes with chronic complication. There's diabetes without complications. So HCC 19 is diabetes without complications, but when a patient gets a complication, it goes to HCC 18. So 19 would not count, then 18 counts. And if a patient gets an acute complication of diabetes, then that's 17 and 18 would not count. So this kind of just shows you that HCC 18 overrides HCC 19 and HCC 17 overrides or trumps HCC 18 and 19. It's just as disease becomes more complex and more comorbidities present, as a patient gets sicker, different hierarchical roles come into play. But most of this stuff is not something you need to worry about when it comes to patient care. But what does matter is you must make sure you use the most appropriate ICD-10 code when coding, and make sure that your team is billing the most appropriate ICD-10 code, and you have support for each disease in your assessment and plan. Make sure if you have diabetes with peripheral vascular disease, make sure you're writing how you made the diagnosis for diabetes and how you made the diagnosis for peripheral vascular disease. So we do have a checklist here. This is a rendition. This is just a artist rendition, but we would have our own version of this that we would be able to share with you. And this kind of shows you all of the different diseases that a patient has. And as we know, pilots, when they're about to take off, they have a checklist. Surgeons, before they open, after they close, they have checklists. So why do primary care providers, physicians not have a checklist? So this checklist takes data from all over the nation. Every single time a patient has seen a provider, all that claims data gets fed into this, and we spit out a one-page checklist that will show you what open care gaps you have for those patients. And as you evaluate them for these care gaps will drop to the middle or the end of the checklist. So we'll talk more about this, but the reality is it is a tool to help you get to know your patients better. And this is a pretty cool slide I like to use that talks about how disease does not exist alone. When we think about disease, there's all kinds of different ways, but if we think of any of these different hexagonal shaped boxes, let's start with morbid obesity, kind of in the middle. A patient that has morbid obesity may or likely has diabetes. A patient that has diabetes may have an amputation, may have chronic kidney disease. If a patient has an amputation, they may have malnutrition. If they're malnourished, they may have depression. If they have malnutrition, they may have an ulcer. If they have morbid obesity, they likely have hypertension, hyperlipidemia, and atherosclerosis, and coronary artery disease. So the point of this is to get you to start thinking. Anytime you see a patient, yes, if they have morbid obesity, well, I should be evaluating for all of these diseases. If a patient has hypertension, I should be evaluating for all of these diseases. If a patient has heart failure, I should be evaluating for all of these conditions. So the idea behind this slide is just to help us remember that disease is not alone. Disease is there, and patients usually don't even know what they have going on. It's very important for us to recognize that chronic kidney disease can be a manifestation of diabetes, maybe not, but if a patient has chronic kidney disease, then we should probably get a PTH done, because if there's a calcium issue, there's a phosphate issue, there's a PTH issue potentially. So let's take a look, and guess what? If they have a PTH issue, maybe they have bone issues, and if they have bone issues, they may have osteoporosis. So there's something to be said for making sure that we think about all of these different diseases that a patient has, and make sure that we're always evaluating patients for all of these different chronic diseases.